Hello. Yeah. So good evening, everyone. Myself, Dr. Sachin Chaudhary from Medical Affairs Team Alchem, would like to welcome you all for today's event, that is Taximo Trust CME. Now at Alchem, we believe that this kind of CME is very vital for medical professionals because it helps them to keep up to date with the new medical information. This ongoing learning ensures that they can deliver a high quality and effective patient care to their patients. So with this vision, we have started this Taximo Trust CME couple of months back. Basically, it is a case-based interactive CME sessions which will be live streamed to 17 locations across India, where during the sessions, our speaker will be throwing some questions to you, and you are provided with the QR code on your table, which you can scan, and then you can register your answer. And last time we started with one topic, that is differential diagnosis in fever, and the response was phenomenal. So today we are going to reveal one more chapter from that series, that is differential diagnosis in GI infections. But before going to the main events, I would request the Ambedkar sir and madam to please come forward for the lamp lighting ceremony. Also, I request our senior leaders to come forward for the lamp lighting ceremony. Thank you, everyone. So friends, as you know that I would like to welcome the speaker for today's CM, that is Dr. Y.K. Ambedkar sir. The name which actually requires no introduction, but still I will call out few of his contribution towards the society. The sir is a teacher, a guide, and orator par excellence. He is practicing pediatrician since 50 years and currently been associated with SRCC Hospital, Mumbai. He also been the faculty in JJ Group of Hospitals, that is in Mumbai. He also has been the past president of IFA as well. Other than the clinical practice, he also has written multiple books and the publication. One of most recent book which I remember is What Doctors Must Learn. Now, this particular book has highlighted many critical issues which are not has been taught in the medical colleges. The few of the issues which I remember is like we must look beyond the science. By simply taking the hesitation, you can able to achieve, or you can able to understand the differential diagnosis as far as 80% of cases. A must read book that everyone should read it. So the kind of commitment, consistency, and the perseverance sir has towards the education and the teaching is beyond the imagination and one's thought. So because of his incredible work towards society, now I request our senior leader, Mr. Rana sir, to please come forward and felicitate Dr. Ambedkar sir. Dr. Ambedkar. Thank you, sir. Yeah. Also, I would request our divisional head, Mr. Vikas Seth sir, to come here and felicitate our moderator for today's session, Dr. Chandan Shah sir. Can we have you on the stage, please? Thank you so much. Sir, I would request you to say a few words about today's event, and then we can start the event. Yeah.
गुड इवनिंग टू एवरीबॉडी। आज हमारे लिए सौभाग्य की बात है और मेरे लिए तो गर्व की बात है आज डॉक्टर अम्बेडकर सर, जो विश्व के पीडियाट्रिक फील्ड में एक रिनॉन पर्सनालिटी है, एक लीजेंड है अपने आप में, हमारे सामने हमें कुछ सिखाने के लिए आप आए हैं। आपको बहुत बहुत धन्यवाद। और अपने एल्केम फार्मा जो इन्होंने इस प्रोग्राम का अरेंज किया और मुझे इनवाइट किया है, उसके लिए बहुत बहुत शुक्रिया। ऐसी महान हस्तियों को सुनने के लिए हम लोग आतुर रहते हैं और कभी चांस मिले कि कभी आपका सर का लेक्चर हो, हम कभी भाग के आपके सामने आवे और सुने, ये हमारे लिए बहुत बहुत सौभाग्य की बात है। और बस इतने कहना कि यार ऐसी महान हस्ती जो पीडियाट्रिक फील्ड में है, आज हमने सुनने को मिले कि हमारे लिए बहुत कुछ हमारे जनरल प्रैक्टिस में बहुत कुछ हमें काम आएगा और हमें वो पेशेंट को दे पाएंगे जो आप कहना चाहते हैं। बहुत बहुत धन्यवाद।
Thank you, sir. Very well said. So here we present to you Dr. Ambedkar, sir. I request you, sir, to please start your sessions.
Good evening, friends. A small request, please come as forward as you can and occupy all these seats so that it's easy for me to get the mic to you when you raise a finger and want to kind of comment on what's happening. Thank you very much for doing that. Please occupy all these front seats. It's easy to go by. Yeah, there are some seats here also. There are some seats here too. So please, thank you very much. I think we all... So this is forward. Okay. See, we all know that the most common problem with all of us is infections. And be it fever alone, be it cough, be it loose stools, the first thought comes to our mind whether we are dealing with infections. And we are reasonably right. Most of the acute problems, especially in children, are often due to infection. But that's not always so. And I think when we are talking about it today, the differential diagnosis of infections, we need to look at the basics first. How do we analyze whether it's an infection at all? And then the next is, if it's an infection, then what infection it is? And with this kind of an introduction, let us get to the basics. Can GI infection present without fever? We said infection is fever. But can there be infection GI without fever? Your comments. Yeah.
Yes, it can be. It can.
Very good.
The immunocompromised patient can represent with the.
Very good. So now we know that fever is not necessary in case of diarrhea to call infection. That's a problem, right? Then how do we really know it's an infection and whether we should give an antibiotic? We will discuss all that. So I think low grade or chronic infection often are presenting without a fever and also depends on how the host is reacting to infection. For example, if it's an immunocompromised host, if it's a host who is taking chemotherapeutic drugs for cancer, he may have no fever at all, but still an infection, and he needs an antibiotic, right? So no fever is not no infection. That's one thing. Then let's look at, can fever and diarrhea present without infection? Yes. Okay. Non-infective inflammation. So if there is a loose stools and fever, it may not even be infection. Like you have seen inflammatory bowel disease. Okay. So again, when no fever, there could be infection. And when there is a fever, there may not be an infection. These are our challenges. And we will discuss with some case scenarios how we get over this kind of a situation. Can diarrhea continue even after infection is controlled? Yes. Like cough continues. Okay. A child or an adult of pneumonia comes fever with cough. The fever may disappear, cough may continue. And you know, the chest X-ray may continue to be abnormal even for a few weeks. Again, a cure of infection doesn't mean that loose stools are controlled. But it may also mean that the infection is not controlled. So again, I'm just trying to revise how medicine is complex and how all of you rightly, mostly diagnose correctly by your experience, not just by science. And science is fine, but an experience is something beyond. And you say, no, I feel this is this. And you cannot tell me why you feel, but you still are right. And therefore, if you look at that, so there could be intestinal delay in the mucosal repair. Okay, so I get a respiratory infection, I start coughing and having fever. Fever quickly disappears, but the cough takes time because the mucosal repair takes time. Same is of diarrhea. To that extent, the parents would come and ask you, the patient asks you, fever is gone, but still diarrhea is not gone. You feel like whether the drug did not work, whether you need to change the drug. So we will have to see all such situations really with that. Can fever continue even after diarrhea stops? I said, fever disappears, the diarrhea continues. We know that. That's fairly common. But can it happen the other way around, that the diarrhea is gone, but the fever continues? Okay. Again, not a common situation, but a probable situation. And we will look at all such issues when we look at that. And therefore, the whole story becomes so complex. And occasionally in children, you get what is known as a parenteral diarrhea, which means a child has, for example, an acute otitis, child has an acute meningitis, child has an acute pneumonia, and the toxin that generates out of that bacteria can cause one or two few loose stools on the first 1 or 2 days, and the stools disappear, and the fever even gets worse. So you need to keep in mind all such combinations, and that becomes really interesting to go by that. Where do I point? It doesn't work every time. Let's therefore quickly look at the clinical approach. Okay. I think the most important point is loose stools are of three types. One is watery, another is fatty. Okay. Large stools, grayish white stools, foul smelling stools. And the third is an exudative. That means there is a mucus, blood, etc. So we have to start first looking at which type of diarrhea we are looking at. And if it's watery, then we know mostly viral infection, but occasionally even a bacterial infection. Okay. So again, a problem. Just because it's watery, it may not mean you don't need an antibiotic, but surely most common cause is watery. But even a bacterial one, and sometimes even a non-infective cause. Then when it is really fatty, bacterial infection is unusual, but parasitic infection is more likely, like a giardiasis. And of course, it could be a fat malabsorption and a grayish white stool, not too many stools, but foul smelling. Okay, large. That typical of giardia, and you certainly need an antibiotic against that, antiparasitic drug against that. And then when it is exudative, which means there is a mucus, blood, tenesmus, almost always it's a bacterial infection, or it could also be non-infective inflammation. Okay, so we know that any type of stool could justify an antibiotic or may not need an antibiotic. Again, issues are not that simple, even in a simple diarrhea, right? And then if you look at that, this is point here on. Oh, point it here. The next is you want to see whether the patient is unwell and dehydrated. Okay, I'm not using the word sickness. Sickness is a little more severe. Unwell is, oh, I'm not feeling too well today. That's fine. Sickness is really, I am uncomfortable. And if he is not all that sick, he is unwell, but he is dehydrated, which means he has a lot of watery stools, mostly viral, you need not use an antibiotic. Okay. But if it's an acutely sick and febrile, then even if there is a watery stools, you might think of an antibiotic. So watery stool does not mean no antibiotic. But what decides the justification of antibiotic is sickness and febrile period. The first one is not so sick, he's unwell, he's dehydrated, but he is not sick. That sickness tells you that there is a need of an antibiotic. Okay. And then if he's chronically sick, oh, I've not been feeling well for a long time, I'm never all right, I always have some loose stools. Invariably, it's neither bacterial nor viral, often parasitic. I think these are simple, basic rules. 99% we are right. Okay, in medicine, you can't be right more than that anyway. The other thing is to go by appetite. When appetite is good, in a child with diarrhea, it's almost a malabsorption and no infection. In fact, there are hardly any diseases where appetite is good. Appetite is the first thing to be lost. But if there's a malabsorption, not due to infection, then he keeps on eating and he keeps on not absorbing, passing stools. And therefore, sickness and appetite, if you add two, watery or exudative, you almost get a diagnosis. Okay? And if you look at that, flatulence and anal excoriation adds to telling you that there is a lot of intestinal hurry or a carbohydrate malabsorption. So viral infections have lot of flatulence, have an anal excoriation, and so also the sugar malabsorptions. And then dehydration, I've already said, and always look for the. See, when you see somebody with diarrhea, you have to put your hand on the tummy. What do you make out? You can't make out anything. Okay. But problem is there. So how can a doctor not first put his palm on the tummy? And then if suppose patient does, what did you know? What did you understand? You are really don't know what to do. But no, it's important. If the abdomen is distended in a child of diarrhea, it's likely to be serious. If abdomen is tender in diarrhea, it's likely to be bacterial infection. So we need to look at carefully whether there is any undue distension or undue tenderness, maybe generalized often. And I think that's how the abdominal examination becomes necessary. But sometimes the diarrhea or whatever infection may come with complications as well. For example, if a child has a severe dehydration, the kidneys may not be working well, and there could be what is known as a pre-renal failure. He may need intravenous fluids. Okay. Sometimes the toxin may produce a convulsion. So diarrhea with convulsion. Okay. So you need to look at whether there could be complications as well. And whenever we are not sure in medicine, and all of you here see the patient on first day, and first day nobody knows what's happening. But the patient wants to know what is wrong. Okay, so you have to tell him something. You can't say, I don't know, you have to wait. So that's, I think, a bigger problem. So we need to be sure that we are not missing anything serious. And if so, then we can just wait. I'm sure all of you know very well how to convince a patient without knowing anything. Okay, we have to learn that. How can I tell you, no, I don't know what is it. No doctor can understand. No test can say. He said, leave me quickly, I'll go to the next man. So we all know how to tell the truth with a lie. But the lie that, properly used is acceptable. And therefore, this is the clinical approach, right? We have now understood the basics. We have understood the clinical approach. Now let's try some kind of a problems. This is the first case. Now you have to scan these papers, okay, and get ready to kind of vote for the options. Okay. If anybody needs help for this, please. I think control. So this is good. If anybody needs help, uh, when you screen this, okay, all these papers, okay, when you screen this, then you will get it on your WhatsApp. You can help them if they want. Somebody who needs help, he is there. Yes, I think there are volunteers who will help. Yeah, they got it. Yes. Perfect. So all of you must be having now. Okay. So are we all ready to? They need help. So I think let's get started. Most of you have got this. Now, this is the first child. A 2-year-old child presented with mild fever and vomiting for a day. That settled. Followed by watery stools 7-8 times. Considered acute viral infection and treated with ORS and zinc. I think fair enough. I'm sure all of you would have done the same thing, right? So now, diarrhea continued next 10 days. Okay. So patient comes back to you and says, sir, fever is gone, but the diarrhea still continues. Now, your action is stool microscopy and culture, start antibiotic, both of the above, or none of the above. Your time starts now. You will get 15 seconds and you choose your option. And majority of them feel it's good to do both. Okay. Now, back to the slide. Now, if I ask you, when did you ask for a stool culture in your practice? Never, no? Okay. No, never. In fact, if you ask for a stool culture, I'll ask you how to collect it. Okay. So, culture of stool is so rarely required. Yes, it is required occasionally. And the way to collect it is even the pot on which you collect should be sterile. And then you have a sterile wooden spoon and you collect it. Not easy. In clinical practice, you don't need it. Rarely you may need it and leave it to somebody who can do it. So, then why do you do stool culture microscopy? Okay. Please note, fever had disappeared. Diarrhea continued. In our first slide, you all said that yes, it happens because mucosal repair takes time. So, how will you know that you will do nothing about it? Only because if the patient is fine, let the diarrhea continue. Mucosal repair takes time. And how will you convince the patient? No, but he is looking fine, no? But he wants stools to stop. No, stools can't stop just because you gave some medicine. We look at it at the end, whether you could give some temporary anti-secretory, anti-motility drugs. Even that is possible. But the point is, You will neither do investigation nor culture nor consider antibiotic, nothing. So what have we learned? Diarrhea may continue, but the patient is fine. And sometimes the patient is not fine, diarrhea is controlled. That is the troublesome thing. So we are treating a patient and we are not treating his symptoms, nor any test is required. So this child did not require anything at all, and we would therefore leave it at that. Now let's get to the second case. A young adult presented with high fever, watery stool 3-4 times for a day, followed by generalized seizure. Okay, make a note. There is a fever high, stools are watery, and next day he throws up a convulsion. Physical examination shows he is febrile, he is drowsy, there is no dehydration, there are no other neurological findings. Right? Now, your options are, is it acute viral encephalitis? Is it acute bacterial meningitis? Is it a simple febrile seizure? Or it is none of the above? Your time starts now. Well, half of you have said it's a simple febrile seizure. You are partly right in the sense that this is not an infection. That's what you're saying. Intracranial infection is ruled out. That's why those who have said it's a simple febrile seizure probably mean that is neither meningitis nor encephalitis. But simple febrile seizure never occurs in age beyond 2-3 years, rarely 4-5 years, but never thereafter. So simple febrile seizure is only for 1 or 2 years of age. Okay. And it's a benign thing. It disappears by itself. You're not worried. This is a young adult. Simple febrile seizures are out. But possibly those who, you wanted to say something? No. So those who possibly wanted a simple febrile seizure were sure that it's not an intracranial infection. That part is right. Okay. Then almost first two are ruled out. Somebody has said none of the above. Is anybody from here? You said none of the above. Yes, there are one. I will give you the last chance because last time also I remember you speak very well. But you can add what you... Okay, is that all right for you? Yes. No, otherwise he will say, I raise the first hand. You will say, I raise the first hand. I will be in trouble. So, but we will have everybody speak.
Yeah. So, in this case, because the person is an adult, he can have any other cause besides the brain infection for a seizure. It can be, say, a tumor or something like that.
All right. Somebody else also raised the finger here.
Yes, myself. Yeah.
You raised the finger. Yes.
Being an young adult, I thought it is not a febrile seizure, and the symptom was not matching with viral encephalitis or bacterial meningitis. So the other option was left was none of the above.
Good. Come, now it's your turn. What have you to say?
Though both this condition has been ruled out, I think this is bacterial infection because of toxins of the bacteria. He got febrile convulsion.
He said that adult started with high fever. Okay. And can I have the slide, please? Back to the slide. Yes. So high fever. So keep in mind that. Now, what are the stools? Watery. We said that watery stools in viral infection is not high fever, just unwell. If it's high fever, You start thinking, could it be a bacterial infection? Though looks like viral. And then he suddenly throws up a seizure, which means there is an intracranial complication. Why not meningitis? Meningitis takes time to get into the CNS, 3-4 days. And what's the story of meningitis? Headache, vomiting. And then after 3-4 days, if you have not treated correctly, he will throw up a seizure. Seizure is very late in meningitis. And almost a seizure in bacterial meningitis is missed for days, not even 2-3 days. So this is a bacterial infection which has not directly gone to CNS, but indirectly gone to CNS. And that is why I said it's a bacteria which has caused toxins. And which is the bacteria which causes common toxin?
E. coli, Shigella.
Shigella. This is a bacillary dysentery. Wait for a day, he will start with his blood and mucus. What have we learned out of this? Occasionally, the blood and mucus, which is the highlight of bacillary dysentery, may be preceded by a complication. Some of you must have seen diphtheria in your early practice. I can see some senior people. And diphtheria came with toxicity. Okay. If you miss that small patch there, you could have myocarditis, you could have something more. So toxin causing, this child required an antibiotic. We'll discuss about antibiotics. So see the fun. Because it's loose, watery stool doesn't mean that now you're not going to treat this child. Where the first one was simple and the diarrhea continued even with that. So this was typically a bacillary dysentery doing that. I just wanted to bring something unusual, which I'm sure each one of us are going to say someday. Otherwise, routine, there is no big fun. You know the secret of medicine. Many get well without us, and few don't get well with it, any one of us. Okay, largely. We take a credit whenever somebody gets well, yes. So that is what it is. Now let's get to the next case. A middle-aged adult present with watery stool for 2 days. I have also brought some older children and adults only because you see kind of a combination of all this. And for me, a 10 and 15-year-old is almost like an adult. So I claim some knowledge, but you may kind of tell me where I'm going wrong as well, because you have seen more of that. Now look at this, considered as maldigestion and treated symptomatically. Fair enough. If some adult comes and says, I have few loose stool, you said, kuch bahar khaya hoga. Okay, wait and watch. He's not having any other complaint, right? Now, diarrhea continued with flatulence. Okay. Past history of epigastric pain, off and on, being treated with drugs and change in diet. Because when his stools continued, you naturally asked him, did you have any such thing in the past? He said, not such thing, but I've been getting pain in the epigastrium. I've been getting flatulence. I've been on some medicines. And there is a diet change. So he's not well as far as his tummy is concerned, but not the stools. Physical examination showed there was an anal excoriation, which means there was some intestinal hurry. The sugars were not getting absorbed. Okay, that much we knew. Okay. Now we have some options to go by. Is it a rotaviral diarrhea? Is it a functional disorder? Is it an irritable bowel syndrome? Or is it a lactose intolerance? Your time starts now. Good. We are all democratic, so we are all equally divided. Okay, that's wonderful. Now, the maximum fellows seem to be in favor of lactose intolerance. Anybody who said here lactose intolerance, just try to justify. Good number, one third. You said that. Yes.
Lactic acid formation and it causing anal discoloration. Acid is lactic acid.
Very good. So he said that that kind of flatulence and anal excoriation does suggest that sugars are not getting absorbed. Okay, good suggestion. Who said irritable bowel syndrome? Good. Irritable bowel syndrome has no definite criteria, but some fixed criteria before you take that. And what are those criteria? It's not a short duration illness. Irritable bowel syndrome is a diagnosis of exclusion, and therefore there are no tests. But it should go on for some time, not continuously. Some days yes, some days no. So this doesn't fit in anything. Functional disorder, again, comes over a longer time. Okay, so probably not. And rotaviral diarrhea almost never occurs at this age. So you are right, you suspected it must be the sugar. But why should it occur in an adult like this? Even in children, we don't see it much. So now that epigastric pain, can you connect the two?
You must have taken prokinetic or what do you call proton pump inhibitors also.
This was just to bring a point that not every loose stool is infection. This epigastric pain that he is going to be often on, he would be on antacids and he would be asked to take milk diet. Adults who are not used to take milk, many of us don't take milk. When we start taking milk, we have a lactose intolerance. And earlier, now today you have a better antacid, but otherwise the magnesium contain antibiotics, aluminum contain antibiotics. They all cause what is known as an osmotic diarrhea. All this child needed was, forget that extra milk and all that. I'm sure some of you who may have been asked to take a little more milk because you have some epigastric problem might start even loose stools. And that's why this was certainly just related to that. This is just to show that not every stool is an infection, but every stool may have an issue that we might be able to kind of relate to. Let's look at the next case. This was an 8-month-old child presented with loose stools off and on for last 2 months. Watery to semi-solid, greenish, no fever, but occasional vomiting. Irritable, appetite is good. Take a note, 2 months of story, off and on. Sometimes watery, sometimes semi-solid. Okay, not a continuously of same time. Greenish in color. Okay, but no fever at all. Physical examination shows irritable child, gaseous abdominal distension, overweight. No other findings. Now your diagnosis is it a chronic viral infection? Is it chronic bacterial infection? Is it chronic parasitic infection? Or none of the above? Your time starts now. The first 3 options are infective. Okay, chronic bacterial, chronic viral, chronic parasitic. But the last option is possibly those who have voted for it seems to feel that there is no infection at all. Okay. So let me ask. I know he has said no infection, means none of the above is his choice. Anybody else who has said none of the above? Good, one third of us have said that. So, yes, sir, please.
Child could be bottle fed, causing flatulence, recurrent diarrhea. Bottle fed, 8-month-old child could be possible.
Right. So he said it could be a bottle fed child, therefore there is a recurrent diarrhea, etc. So that is that.
This is a case of malabsorption.
Okay. Why do you say that?
Okay, so instead of good appetite, his weight is not in.
See,
Whether it is lactose intolerance.
okay, lactose intolerance, yes. See, I wanted you to pick up every word from this story. And what he picked up is good appetite. I said to begin with in our discussion, which disease has good appetite? Okay. There are hardly any diseases in medicine with good appetite. One of them is this. And what is this? He is not getting enough food. That's why he is irritable and he wants more and more, but he is not getting the right kind of food. Could be a bottle feeding with a dilute milk. Okay, whatever the cause. That's why this is not an infection, but this is some wrong diet going on. Again, causing diarrhea. But how did we make out? Good appetite. So make a note of everything. I think what these cases are teaching us is how important it is to take a good history. Okay, we hardly would ask anybody, how is your appetite? He would fire back and said, I am sick and what are you asking me? But there could be occasional problem with good appetite and a disease, and the problem is somewhere else, and this is one of those, right? So this is just to make those points at all. Let's look at this one. 15-year-old presented with loose stools 3 to 4 times a day, semi-solid with mucus, occasional blood, and fever off and on for last 2 months. Loss of appetite and weight. Physical examination, he is chronically sick. He has a gaseous abdominal distension. He has a generalized mild tenderness. Make a note of every part of this story. Each part of the story might have something to tell us, and therefore correctly get on to all this. Problem is for last 2 months. There is mucus, occasionally blood as well. And he has obviously lost some appetite and weight. And there is the generalized distension, also mild tenderness. This is the story, right? What is your probable diagnosis? Intestinal tuberculosis, chronic amoebiasis, celiac disease, or Crohn's disease. That's an inflammatory bowel disease. Your time starts now. Well, most seem to favor chronic amoebiasis. Okay, some also felt that it could be intestinal tuberculosis. Let's decide. Can we have the slide back? Who said chronic amoebiasis? Anybody for chronic amoebiasis? Yes.
Typically, we are having mucus in the stool, blood with tenderness in the abdomen. And amoebiasis is normally quite common chronic, known for chronic disease.
Absolutely. A good thought. What looks little unusual, see, we are putting some options which are very close to each other. But he gave the right thinking process. Okay, he said, yes, there is the mucus, there is the blood, etc. Okay, and look at what is happening now. One is that there is a fever off and on. I mean, chronic amoebiasis, fever is rare. Okay, so take a note of it, but good thought. See, we have brought cases to you because there is a small difference here and there, which makes us, what are we learning? What looks suddenly simple, we may still take time to kind of correctly analyze. That's why this is not chronic amoebiasis, but a good thought. Then the next common was intestinal tuberculosis. Anybody who can justify that? Intestinal tuberculosis?
He's having loss of weight and appetite, and fever is on and off with all the symptoms.
So again, like chronic amoebiasis, chronic tuberculosis. If you are asked how do you diagnose tuberculosis, chronic fever off and on looks perfectly fine. What we wanted to impress on you is that intestinal tuberculosis does not start in the intestinal mucosa, but it starts in an intestinal submucosa. Therefore, diarrhea is almost not a symptom of chronic tuberculosis intestinal. Often, there is a alternate constipation and diarrhea, and more commonly, it presents in older children and adults as a subacute intestinal obstruction. Because when there is a submucosal lesion and the healing takes place, the intestine starts showing obstructive signs and you get constipation, vomiting, and then sometimes an overriding little loose stools. And the books will typically say alternate constipation and diarrhea, but not diarrhea with blood and mucus. When it is a celiac rarely presents with fever itself. It is a malabsorption, yes, immunological, and therefore this is a typical Crohn's disease, inflammatory bowel disease. Okay. But very close to chronic amoebiasis, very close to chronic tuberculosis, and it is not rare that the endoscopist also makes a mistake between all these. Because in India, if your stool shows some amoeba cyst, it doesn't mean that you have amoebiasis. Cyst sponsors are always there. So these three conditions simulate each other so much that we may have to really break our head and say, look at very carefully what it is. And if you see typically a Crohn's disease, there is a neutrophilic leukocytosis, there is the platelets are increased, and the serum albumin is going down because of a severe inflammation. So, but both the options were very close, and this was obviously a Crohn's disease. Let's look at the sixth one. A young adult presented with abdominal pain and loose stools, off and on for last 4 months, loose stools at times with mucus, 2-3 per day, mild to moderate abdominal pain, no fever, no vomiting, appetite variable, no loss of weight. Physical examination, NAD. You know what is NAD? You know now. NAD is not actually done. Okay. So that is NAD. But anyway, no abnormality detected. And now your options come in: tuberculosis, chronic parasitic infection, inflammatory bowel disease, or none of the above. Your time starts now. when we all used to appear for examinations, and if we are short of time, we had to leave some subjects optional. We would leave the subjects optional, questions optional, which were asked in the last year's examination, hoping that they are not repeated. Right? We all must have done. So I'm not going to repeat inflammatory bowel disease immediately. Okay, I just talked about it in the previous slide. Okay, so like what all we used to do. But by chance, the examiner might pick up the same thing again. Yes. So the point is tuberculosis. Again, I have already said that loose stools is not a problem of tuberculosis intestinal. So that is not that. Chronic parasitic infection, again, if you look like no loss of weight is an important parameter here. Why no loss of weight? He's suffering for 2 months. Okay. Even then, and his appetite is variable, which means some days he eats well and some days he doesn't eat well, which itself tells me that it's not the disease that is doing all this. And this is typically a story of an irritable bowel syndrome. Irritable bowel syndrome is diagnosed by exclusion, but it has to go on for a few weeks or few months without much disturbing the health of the person. But he's still sick. He's carrying out all thing. He has not lost weight, which is an important part, and still he has a disease. It is very close to what we call as a functional disorder. And both are almost similar. Multiple causes. Most important causes are anxiety, stress, hurry, worry, curry, all that. But who doesn't have that today? The question is whether you can cope up with it or not. And that is why this was just an irritable bowel. Now we will discuss the last case. Okay, which I have given some more details, more than what we have been discussing so far. Now let's look at this one. A young adult presented with moderate fever and occasional loose stool for 2 days. Okay, young adult, 2 days story with moderate fever and occasional loose stool for 2 days. Now, what is your action? Symptomatic therapy? In addition, CBC stool examination? No, take the last one out. Okay, it doesn't matter. Which is your action? Symptomatic therapy? In addition, CBC and stool examination? Or in addition, cefixime? Your time starts now. And majority don't want to do anything at all, right? Well, but let's see who has asked for CBC and stool. Not a bad idea. He's also not giving any drugs, but he wants to make sure what it is. So who has said CBC and stool examination? In one of our such meetings, only one person had given the right answer. Okay. And I said, who is this? Now nobody raised the finger because he said, I'm the only fool. The rest of them are wise. And I said, he's the only right answer. He said, sir, I have the one to with that. Okay. My question to you is CBC or a routine stool examination helpful to decide treatment? That is what I want you to give a thought. 2 days of fever. Is CBC good? Is CBC useful?
Anything in CBC or
So he says CBC in the first 2 days, what are you doing? CBC in the first 2 days is almost useless. Why? Because every infection has a neutrophilic leukocytosis to some extent. And what's the cause? Polymorphs are like ordinary constables. Anything happens, they are the first to be there. Okay, theft occurs, fire occurs, accident occurs, minister is coming, Bollywood actor is coming, whatever the cause, those constables are always there because they are large in number and they are the first to reach. Polymorphs are like that. But the fire engine comes after some time. Then you know it's a fire. Okay, people are running about away from the site. You know there is a bomb blast. But first is the polymorphs. So first 2 days, don't do CBC at all. But you can do CBC only in one condition of fever, right? Even in the first hour, which is that condition, malaria, peripheral smear. Not CBC, but PS. Otherwise, CBC never in the first 2 years. But sir, you said not even a stool examination. What? Your wife is not a pathologist?
May not get anything for treatment purpose. It may not.
So stool examination, he said, does not give any great idea. It shows some WBC, some pus cell, doesn't tell me what to do. And therefore, and cefixime is out of question. Okay, we have no reason to start an antibiotic in a hurry. So exactly, this is what was done. CBC and stool was normal. Somebody who did not listen to you, he still did it. Okay, and it was normal. No antibiotic started. Fever became high on day 4. Okay, and with occasional rigors, but no more stools. Stools stopped. Fever increased. And even occasional rigors. First was moderate fever for 2 days. Now by day 4, the fever is worsening, but stools have disappeared. We have discussed this to begin with. Any combinations can occur, right? Now you need some more information? Yes, I will give you some more information. Physical examination on day 4 showed 104 fever. Okay, his fever has gone up. He is very toxic. He has got a mild abdominal distension and he has a generalized mild abdominal tenderness. These are the findings, right? And at this time, we did the CBC. CBC was 11 grams hemoglobin. WBCs were 4,500. Polyps 34, lymphocytes 58, monocytes 8, eosinophils 0, platelets 70,000. What is your action? Urine microscopy and culture. Start cefixime. Instead of cefixime, IM ceftriaxone, hospitalized, and IV ceftriaxone. Okay. What do you want to do on this really? Your time starts now. Well, most of you favor hospitalization and ceftriaxone. Okay. I'm sure when you hospitalize a patient, he must get an antibiotic, so that is all right. In fact, at the entrance of the hospital only, they must start an antibiotic. You know, whatever the problem is, IV fluids and antibiotic, oxygen, and if you are coughing, nebulization, or kya karega? Okay. So now just hospitalization is all right because he is getting sick. Okay. But why IV antibiotic? Where is the hurry? Stools have gone. And what are you thinking of? Bacillary dysentery, viral infection, inflammatory bowel disease. How do you jump to say that you want a intravenous ceftriaxone. Any idea? Yeah.
Because platelet count is low, so it is better to hospitalize and give IV ceftriaxone.
You're right. Better to hospitalize, yes. But better to give ceftriaxone may not be acceptable because you are not sure what it is. Okay. And after he is not well with ceftriaxone, you will start looking at investigations. You got already a count I showed you. Count was 4,500. Lymphocytic. Okay. And if that is so, then why do you want to give ceftriaxone? Why don't you hospitalize and observe?
Step increase. First it was over side. Now it is increase. Neutrophil is comparatively lower side and lymphocytes are increased.
Give him a clap. He said it's a step ladder pattern of fever. First 2 days moderate, then became sick. So that's one reason why he called it an enteric fever, but also there were some intestinal symptoms and signs. This child started with 1-2 stools, intestinal symptom. There is a mild abdominal distension. There is a mild tenderness. So this is a story of a typhoid fever. Okay. What have we learned? Stools, loose stools may be the onset of typhoid also. At first 2 days, you will not know it is typhoid. And that's why whoever was treating this child waited for 2 days, did not even do CBC and stool. But on day 4, we did that. And what was the day 4 CBC report? Leukopenia, 4,500. Lymphocytosis, but more important is monocytosis, 8. Eosinopenia, eosinophil 0. And thrombocytopenia. Combination of leukopenia, lymphocytosis, monocytosis, eosinopenia, and thrombocytopenia. On day 3, day 4, he had said earlier, we will not do CBC first 2 days. But by the time it gets worse and you did a CBC, that CBC itself would have told you, oh, this is a typhoid fever. That's one important infection, acute bacterial, which does not present with neutrophilic leukocytosis. And more than lymphocytosis, yes, there is a lymphocytosis also, but there is a monocytosis. And there is an eosinopenia, eosinophils were 0, and thrombocytopenia. Symptoms suggesting step ladder pattern, but today's step ladder pattern may not be there because quite a few children are immunized against typhoid, and therefore the typical pattern of typhoid step ladder may not be seen in most patients. But if it is there, it's certainly there. But even if it's not step ladder, the patient starts looking more ill, which means step ladder only. He's looking more sick. And the count on day 4 would have told you straight away, do a blood culture and then start whatever you want. And obviously, the 3rd generation cephalosporin is today the drug of choice. Point is, loose stools could be typhoid as well, but the stools don't continue to be loose. In fact, many of them may not have loose stools also, but some intestinal symptoms. And that is what exactly. Now see what happened further. This child was started on cefixime. He decided not to hospitalize. Now, on day 8, less toxic, tumid abdomen. Liver has come out 2 fingers, not tender. Spleen is just palpable. Typical enteric. Fever is coming down, right? So now let's see what happened. We'll tell you what happened next. On day 8, patient come back to you again and say, sir, fever is still there. Okay, 100 degrees. Looks better. Appetite has returned. Abdomen is soft, not distended. Liver and spleen are still there. Now you have treated for a few days. Patient is worried. He came to you only for fever. Stools had disappeared and he wants fever to disappear. But it has not happened. Now the question is, what is your action? Repeat CBC while continue cefixime, change to ceftriaxone. Okay, that was our first choice earlier. Add anti-malarial therapy or even considering TB. I told you this child, when he became 104, there were some rigors. Your first slide said occasional rigors. So the question is, am I missing malaria on the top of typhoid? Okay. Now, what is your action between these four? Your time starts now. Quite a few brave people who said, don't worry, continue cefixime. Okay. Who are these brave people here? Oh, wonderful. Sir, let's see whether anyone else is brave. Otherwise, I'll come back to you again. Quite a brave decision. Patient is still worried, sir, itne din ho gaya, bukhar abhi bhi hai. Oh, there is somebody there who wants to be also keeping quiet.
That is multiplication of the bacteria is still going on, and that is why.
Very good. Okay. He said that it's going to take time. What have you to say?
Sir, the appetite has improved and the fever has also come down. So he's improving basically with cefixime. And it takes anyway 14 days.
Both are so correct. Okay. For them, fever is not the last thing to get. What have we learned in typhoid? The fever is the last to disappear. Much before that, everything else is coming back to normal. Appetite is returning. He's feeling good. He has no abdominal tumidity. He has no abdominal distension. But the fellow wants the last symptom also to disappear. You must have seen in every time in a simple infection also, when they come for fever and cold cough, and you say it will disappear. After 2 days, they come back and say, बुखार नहीं है मगर सर्दी खांसी है ना. Then thereafter खांसी गए तो अभी भी सर्दी है. उसके बाद everything is all right मगर अभी भी खाना नहीं खाता बराबर. That means the symptoms continue, but the patient is disease is already better. What have these two gentlemen have said? Fever should not worry us. Then what is the corollary? In typhoid, we must upfront tell them कि 3-4 दिन में बुखार कम हो जाएगा मगर निकल नहीं जाएगा. Then how do you know he's all right? Oh, he feels well. He wants to eat little. His abdomen is looking good to me. Okay. And what will happen? Can we have the slide back? And therefore, all we wanted is nothing here and stay continuously with TB continue. That we wanted to go by. And let's see what happened subsequently. CBC was repeated because they were worried. What is your comment on that CBC? Does it show convincingly that patient is improving? what is the parameter in this repeat CBC which you can bank upon and say, this is the proof he is already getting better. They have already given us, both of them, the symptomatic improvement. And the point I'm making is that in any acute viral or bacterial infection, when you do a count in the first 2-3 days, eosinophils are almost zero. In typhoid, same. And many times the fever may still be 102. But if the repeat count shows eosinophils are 2% now, they were zero earlier, you could tell the patient, wait for another 4 days, you will be absolutely all right. Return of eosinopenia to back to normal is a good indicator. Occasionally, the fever may not even drop down from 104, 102. 102 is also equal worry. At which time, you take the help of eosinophils appearing is a first sign that wait for next 2 days, बुखार और कम हो जाएगा. Patient will be impressed by your coming so correctly that after 2 days he said, आपने बोला था, बुखार कम हो गया. Eosinophils are important. Problem of eosinophils are some part of the population is already allergic. So if I'm an allergic fellow, I have 8% eosinophils. If I get typhoid, it becomes 4 and you call it normal. So you may miss eosinopenia caused by typhoid because, and nobody knows what is, you can't ask the patient, pehle ka eosinophil kitna tha? He said, I have not done it. So that is a problem. Further, big problem is most of the laboratories do the counts by automated chamber. An automated chamber, except the latest 4th generation automation, most of the laboratories, even in Mumbai, have 3rd generation automation. And what does it do? It separates polys, lymphos, and others. It cannot differentiate between monocytes, eosinophils, basophils. They come in others. And for those others, the pathologist has to say the smear, which means again a problem. So if the others are 8, he decided 3, 2, 2, bas. And then you and me take it very seriously because we have learned medicine. So these are the inherent problems. Okay. And a good pathologist has to really look at the peripheral smear and do that. We'll end up in another 5-8 minutes. Is that all right? Yes. So this shadow of febrile on day N, as both of you said, do nothing, and that was the right answer. We have already said this stool microscopy, acute diarrhea, not really worth it. What is your action if reducing substance in the stool is detected? Acute diarrhea. It's getting less fashionable now, but for some decade ago, every pathologist was doing even a reducing substance. Now all of us have understood we should not reduce to that low level. So what is this reducing substance business?
Lactose intolerance.
And therefore, every loose stool shows lactose, and it doesn't mean you have a lactose intolerance. Okay, every loose stool shows that. So don't do. Lactose intolerance is extremely rare. Yes, we saw one example, but therefore never ask for a reducing substance. What is the significance of yeast in stool? It's a fungus. You start treating antifungal drugs. Many times you must have seen stool report, yeast. Okay.
Proper collection technique.
So contamination. Okay. Don't blame the pathologist. I have a good pathologist. So he is taking all care. Okay. So any comment?
Maybe because of a higher antibiotic.
Because of higher antibiotic. No. Yeast is a normal point in the stool examination. Okay. So it doesn't mean anything. Like a streptococcus is always in our throat. Question is, you want to see it? Yes, it is there. It doesn't mean fever is streptococcal. So yeast in the stool has no importance whatsoever, and therefore ignore it. What is the significance of fat globules in the stool? Sometimes they report, no? Pathologists want to impress on us few fat globules. Now, what do you make out of that? Again, any loose stool, you are not digesting and absorbing everything, no? Few fat globules have no reason. It's not a fat malabsorption. So ignore yeast and ignore those fat. Indication of stool culture, we already talked about it. No indication whatsoever for us. When do you consider malabsorption studies? Extremely rare, but malabsorption is a diagnosis of a chronic loose stools with a good appetite. And they're without fever, without pain, without tenderness, not a common thing at all. And is imaging necessary in intestinal diarrhea? What do you think? We should do plain X-ray abdomen, ultrasound, nothing. Yes, obviously nothing. Why do you want to do that? Okay, so there is no point in imaging at all on that. What is the drug of choice for symptomatic? We said loose stools may be of no concern in terms of a disease. You don't need an antibiotic, but he wants a relief. He's going 10 times to the washroom. He said, do something. Then what drugs do you use? There are drugs, right? Earlier days, some of the seniors here may have used kaolin, mixture, whatever. Okay, now you have better drugs, anti-secretory, anti-motility drugs. Which drugs do you use or you don't use? Patients want a relief, and he's justified in asking for a relief. You can't say that, okay, you're losing water, no? Take more water. No, but that's fine. So which drug do you use?
Sir, sometimes we have to give the drugs because as a placebo effect also, and as for anti-secretory, we are giving resica.
So resica. Probiotic also. Okay. Fine. Okay, good. So we will discuss this. So we already know you have a choice, loperamide, resicodotril. We all agree that we need a relief for the patient. Okay. Irrespective of science. See, the pharmacologists always teach there is no cough syrup worth prescription. But the fellow wants to get relief of his cough, no? Okay, he's not bothered what science says, what your book says. So diarrhea is something similar. What normally we do is that these drugs are not very safe in young children. So don't use it in small children. Especially anti-motility drugs can cause something like a paralytic ileus. But if you look at an older children or an adult, what is called as a traveler's diarrhea, where there is no infection, but some kind of indigestion, malabsorption, you need a relief. He said resicodotril. Okay, fine. You ask any of that, loperamide. I'm sure some of you do use that, and it is justified because he wants a relief. See, we may not be able to cure something. Cure may be natural, but the symptom relief is equally important. So that is really not a problem. We'll go fast on that. Doesn't matter. Okay. We'll go further. What about management? Acute onset, high fever, loose stools, etc. You have to use. Okay. Bacillary dysentery. Which drug do you use? Cotrimoxazole, amoxicillin, quinolones. Which drugs do you use?
Depending on the age factor.
Okay.
If it's adult one, we can use quinolones, or if you are a child of, say, maybe cephalosporin group.
Any more thought on that? Any thought? Which drug would you use for bacillary dysentery?
Uroquinolones.
Uroquinolones. Any idea, sir? Any idea about it? Which drug would you use for a bacillary dysentery?
Gentamicin or something.
Okay. So the point I want to make is that the correct answer really would be depending on local epidemiology. And what is local epidemiology? It really means that your own experience. Oh, this drug works better. Okay. Cotrimoxazole is a cheaper drug, but it is not the best drug today for varieties of reasons. Of course, when the antibiotic is not used for a long time, it becomes very likely that the organisms will work. That drug will work against that. Okay. Otherwise, misuse will cause resistance. Amoxicillin also will work. But let's reserve amoxicillin for only gram-positive organisms, respiratory. So while amoxicillin works, not a good idea for this. You want a specific gram-negative one. Now, what are gram-negative oral ones? Cephalosporins, okay, or quinolones. Don't use quinolones. Don't use quinolones as much as possible. And the reason is that today, with increasing incidence of multi-drug resistant TB, quinolones are likely to be used. So let's not use amoxicillin for dysentery. It may work. Let's not use quinolones also. Okay. The only reason for use of quinolones could be a UTI where the urinary concentration is pretty high. But barring that, no. Avoid use of drugs which have a specific purpose to save life. Quinolones are one of those. And therefore, today the drug of choice is a cephalosporin. Cephalosporin against gram-negative. So not the first generation cephalosporin like cefalexin. So you need to go to second generation or third generation. And that's why I have put down that the typical of bacillus gram-negative antibiotic, food poisoning could be due to staph also. But otherwise, ceftriaxone or ceftriaxone is parenteral, so cefixime. And today, possibly for typhoid or gram-negative intestinal organism, the drug like cefixime for home treatment is an ideal thing. And we gave reasons why others will act, but not a good idea at all on that. So that is what is one point that you remember. We have already said that watery stools in a sick patient may suggest a possible bacterial infection, and we saw a bacillary dysentery doing that. Acute onset moderate fever, occasional loose stool, we saw typical typhoid. And therefore, in general, an antibiotic required for a bacterial intestinal infection, a cefixime is a good idea. And the reason we said, right? We were often on constipation, that is intestinal TB, not diarrhea. We will not discuss much about management of diarrhea without fever because that doesn't come in today's discussion. But yes, without fever, you may have viral diarrhea, malabsorption, whatever, and they don't need an antibiotic. What's the take-home message? GI infection may present with or without fever. Clinical differentiation is not easy, though there are clues for a probable etiology. Routine stool microscopy often fails to confirm etiology, with the exception of parasitic infection. Stool culture is rarely necessary. No antibiotic in absence of sickness with blood and stool. This is important. Any child who is sick, febrile, okay, having exudative diarrhea, very likely a bacterial infection, short duration. Long duration could be inflammatory bowel disease. And I think that is where we choose that. Selective use of probiotics. You said about probiotics. So, what's your comment on probiotics? Today, the market is full of probiotics. Okay. My grandmother knew what is probiotic. She did not know the term. She used to tell us to take a curd and rice for diarrhea, and that was probiotic. She did not go to school to know probiotics. Today we are flooded with probiotics, and each one feels the other is better. No, mine is better. So, which probiotic do you use? What is funny, no? We use antibiotic, probiotic, postbiotic, prebiotic. How many biotics are we using? And antibiotics are already causing trouble. So, what probiotics do you use?
Usually I give Renifol or Visilec, or nowadays the rescues are coming up, probably. And Introgermina or
Introgermina, lactobacillus. Lactobacillus or introgermina.
Okay, good. So, the commonly used are Saccharomyces boulardii, yes, Lactobacillus GG. There are many now. And when there are many, there is always everyone who says, for this, I am better. For that, he is better. Useless. To my mind, let us decide where is the need for a probiotic. Probiotic is a selective use only in chronic diarrhea. In acute diarrhea, probiotic is useless. Okay. And only in chronic diarrhea, we are not sure what more we could do. So probiotic, but probiotic may not help. But giving probiotic as a trial is a reasonable, good idea. Okay. And why I wanted to bring this point at all is that today the market is flooded with probiotics. And probiotics like vitamin D. Today everybody is vitamin D deficient. And vitamin D is supposed to cause every disease. Even psychiatrists also feel it could be caused by vitamin D. And some very knowledgeable person, while giving a talk on vitamin D, said only one disease cannot be treated with vitamin D at all. And I wish that also starts getting treated. So he said, you know which disease? Corruption. If vitamin D works against corruption, the whole country will improve. But that has not happened. Except corruption, every disease is treated by vitamin D. Probiotics has almost gone like that. So don't use routinely. We have almost discussed everything. Stool binding agent, we have already said that. Okay. Thank you very much. I think this is all that I wanted to say.
Thank you so much, sir. That was indeed a great talk.
Specific questions? Okay. Don't ask a private question. I had a child and I did this and my pediatrician said this. What is your answer? No. Oh, yeah, there is somebody there.
Role of zinc in acute diarrhea.
Role of zinc in acute diarrhea. A good question. See, what happened was, at one time, parents were unhappy that the doctors are not giving drugs for diarrhea. Okay. And you say ORS. But what is ORS? You continue to lose stools and I will keep on replacing. My problem is not that. My problem is you stop the stools. So now, what WHO found out was that diarrhea is more common in undernourished population. In fact, the diarrhea is called a nutritional disease. Those who have good nutrition don't suffer from diarrhea. They suffer from overeating and indigestion, like most of us do. But you don't need infective diarrheas. So the point is, zinc came in because nutrition being poor, diarrhea common in such population, therefore, people thought zinc should be given to everybody. Now, when WHO talks about everybody, they talk about every socioeconomic group, everything across the world. In patients that normally you see are not all those malnourished. So you are right in asking this question. Zinc is prescribed for acute diarrhea in children. And what is the literature support? If you give zinc, you will get well in 3 days. And if you don't give zinc, it will take 4 days. Now, who has done all this studying? I remember in UK, in Britain, earlier days, maybe 3-4 decades ago, there used to be a dictum. If you treat cold with medicine, it will just disappear in 1 week. And if you don't treat, it will take 7 days. Okay, so you say, oh, 7 days? No. Give me treatment. 1 week is better. So I think zinc is that. Message is, if you're seeing a malnourished person, give zinc. It's harmless, fairly safe. But I don't think zinc should be. Recommendations are there. Recommendations for the entire population, right? But a good question. Zinc is always being taught today for diarrhea. Any other question?
Sir,
Hello. Sir, this is Dr. Diwakar Mishra from Gorakhpur.
sir,
My question is, which test we will go for the typhoid fever, sir?
Test we should do.
Pardon?
Which test we should do for typhoid fever? Which test?
Tell me, Lal.
Which test we should do for typhoid? Test, investigation.
Investigation, sir.
They're asking.
No, I have not understood a question.
Which test we should do for typhoid fever?
Test for
Investigation we should do for typhoid fever.
investigation. We have already said the limitations of investigations. Okay. Routinely, there is no investigation required. Okay. Investigations are required when the diarrhea continues and we have no answer. Those are malabsorption things. So investigations are not required for routine cases at all. And in acute diarrhea, no question. And if we are discussing infections, even in bacillary dysentery, the diagnosis is clinical. Whether stool shows mucus or blood is not important. So I feel for any acute infective diarrhea, or for that matter, inflammatory bowel disease, the routine stool examination is not necessary, but other tests may be necessary depending on non-infective diarrhea. Like an inflammatory bowel disease, today endoscopy is a must, but not otherwise. So no investigation. Okay.
so sir, that question was related to typhoid fever, sir. So what investigation we supposed to do in a case of typhoid fever?
See, when we are suspecting typhoid, it's not a stool examination. And we are treating a fever of unknown origin. Okay. When it's a fever of unknown origin, yes, no question. I showed you the CBC, and if CBC was suspect of typhoid, I also meant that you should send a blood culture, but not for a GI infection causing diarrhea. Typhoid, yes, of course. Okay, there is no doubt at all. But the bacillary dysentery that cause convulsions, even that doesn't need CSF. That doesn't need a CT scan. Typhoid, of course, yes. Okay, it goes without saying. All right, yeah.
So we'll go one by one. Surat team, do you have any question?
Hello, sir.
Yes,
Sir, hello, sir. From your Chennai, we have question, sir.
Yes, go for it.
Sir, is there any role of rifaximin in acute diarrhea, sir?
Role of rifaximin in acute diarrhea.
Roll on.
Rifaximin in acute diarrhea.
I think acute diarrhea is rarely requiring any treatment. Okay, any treatment. If it's a bacillary dysentery, we already discussed that. Otherwise, if you want to use resicodotril or any such anti-motility drug, that's a different story. But otherwise, no drug. See, today the medicine is becoming complex because there are many reasons not to prescribe at all. And that becomes very difficult. So I don't think there is a need for any specific drug except what we have already discussed.
from
so-
Ahmedabad.
Sorry, Ahmedabad.
Yes, Ahmedabad, sir.
What is a food restriction in acute diarrhea for first 2 days?
Come again.
Food restriction in acute diarrhea in first 2 days. What to eat and what not to eat.
Food restriction. What food we should avoid?
Diet.
In acute diarrhea, sir.
See, in acute diarrhea, there is no change in diet required at all. In which condition do you need a change in diet? First thing is, majority of illnesses don't have appetite at all. So where is the question of diet? But no diarrheal disease needs a change in diet except a chronic diarrhea. Chronic diarrhea we are not discussing. Chronic diarrhea is a different story. For example, if you have a lactose intolerance, you will have to cut down milk. If you have a fat malabsorption, you may have to cut down fat. But in acute diarrheas, and today we are largely discussing infective diarrheas, there is no need to change the diet at all. But there is no need to force the diet also. Okay, he can eat what he likes. Obviously, by what he likes, I mean not unhygienic food, hygienic, soft food, not much oily food, not much spicy food. Yes, that much is for the diet.
Surat team, do you have any question?
Sir, what is your opinion about typhoid and Vidal test?
What damage?
What is your opinion about typhoid test and Vidal test?
Typhoid is useless. Should be banned. Don't use typhoid. Typhoid is banned all over the world, except in few laboratories in India who do it. Typhoid is a useless test.
And Vidal test, sir?
So next, Indo team.
Vidal test. Your opinion about Vidal test?
See, we all know this very well. No antibody test is dependable. Vidal test is diagnostic. Only after 5 to 7 days, you show rising titer. By then, the patient may have risen to a very high level or has improved also. Who depends on Vidal test today? If most of us are Vidal positive, most of us are tuberculin test positive. Okay. So if you are abroad and if you lose your passport, you tell them, do my Vidal and tuberculin test. You will know I am an Indian. And if you like, do my stool. I will have amoebiasis. Where is the problem? So these tests have no use, right? Yeah.
Team Indore.
Indore. Huh? I'm Dr. Pramod Bansod from Indore. We get many patients who say that whatever they eat, they get diarrhea in 4 to 7 times in a day for so many days.
Can you please repeat the question?
Many patients we get, they complain that whatever they eat or drink, they have to go to toilet for 4 to 7 times in a day.
Okay, use the mic.
Many people say, patients say that when they eat or drink anything, they have to go to the toilet 7 to 8 times.
Inflammatory.
They have to go to the toilet many times after whenever they eat or drink something. What is the reason for that?
See, the question is, whenever you eat something or drink something, there is a gastrocolic reflex.
Sir, voice was not getting, sir. Sir, question from Ahmedabad, sir.
Hello.
Okay.
Hello, sir.
Yes, go for it. Yeah.
You
can repeat the question. Sir, question from Ahmedabad, sir.
Yes, please.
Sir, I am asking about in childhood, sometimes we feel. Hello. Hello.
Yes, you are audible.
I am asking in childhood we feel sometimes watery diarrhea. If any deficiency in pancreas, indication.
Use the mic, use the mic.
Any indication for watery diarrhea in pancreatitis? Watery diarrhea in pancreatitis
In childhood.
in childhood, in children.
Treatment, sir.
No. See, again, the same thing that in case of watery diarrhea, what is more important is to kind of pick up what's the cause. And if the cause is simply a viral infection, then we have answered only one question that he had asked. Zinc and ORS is acceptable. But the question is, ORS very much. But zinc, optional to my mind, recommendation, yes. Zinc and ORS for all watery stool. But a watery stool may be bacterial infection as well. We have seen that. And therefore, if watery stools is not bothering, wait and watch. If there are too many, like in a viral infection, certainly hydrate. No much drugs are required.
Yeah, thank you for the.
Sir, vegetable sense.
Wait, we'll go one by one. Lucknow team, do you have any questions? Lucknow team?
Hello.
Yeah, go for it.
Any questions from Indore? This group?
Wait, Indore team, we'll first ask the question from Lucknow team and then we'll come back to you. Yeah, Lucknow team, ask your question.
Any questions, sir?
Okay, then we move to the next one. Vijayawada.
Sir, one question.
One question from Indore.
Yes, go for it.
Hello.
Sir, we could not listen the answer for gastrocolic reflex treatment.
So, sir, he wants to repeat your answer in the gastrocolic reflex. Gastrocolic reflex, can you please repeat your answer on that?
I answered gastrocolic reflex.
Yeah.
I talked about gastrocolic reflex. Gastrocolic reflex is not seen in adults unless you have an anxiety or stress, which is rare as a manifestation. In children, gastrocolic reflex is normal. In an infant, every time the child passes stool, it is not abnormal. So just leave it at that. Gastrocolic reflex is not really a problem at all. It's not a disease.
Okay, Bareilly team, next question.
Hello. What about the travel diarrhea and what management for it?
Traveler diarrhea, sir.
Yeah.
Traveler's diarrhea and its management.
Traveler's diarrhea is a syndrome where there is no cause. It could be viral infection, it could be indigestion, it could be related to food and do nothing, just a symptomatic therapy. That's why called travelers. Why traveler's diarrhea? During travel, you are eating something different. That is all. So it's not a disease by itself and it doesn't need any specific treatment. Of course, while travel, you can get any infection, then it becomes an infectious diarrhea. Okay? Yeah.
Okay, any questions from Bareilly team? Bareilly team, any question?
Indore. Dr. Motwani from Indore.
Wait, we will take questions from Indore later on because there are some other sites they wanted to ask questions. Bareilly, unmute and talk.
Use a specific diagnosis by type blood, ultrasound, X-ray, and urine RMR. All things are normal.
Sorry, can you please repeat your question?
Sir, patient complained repeat typhoid fever. How to diagnose a specific diagnose and ultrasound, X-ray, and urine RMR. All things are normal.
So, sir, a patient is having a typhoid fever and he wanted to understand the investigation, how to manage.
How to manage typhoid?
Yeah, typhoid fever with the antibiotic.
Well, I'm all ready as a student to ask me a question, but how to manage typhoid? First thing is make a diagnosis of typhoid. And if you are surely of typhoid, do a blood culture, confirm the diagnosis if possible. And we already said, use a third generation cephalosporin, either oral cefixime or intravenous ceftriaxone. And that's it. You continue it for at least 4 or 5 days beyond the defervescence of fever. That is the way to go about, right?
Okay. Thank you so much, sir. We have no more questions. Now I request our senior leader, Mr. Rana Bose, sir, to please come and give vote of thanks.
Hello. Indore.
Yes.
Main question from Ghaziabad.
Hello. Sir, Lucknow team, one question is there. Sir, Lucknow.
Indore.
For one session, I think it is simply mind-boggling. And so much of progress coming across the country from you. It makes a lot of difference.
One,
One of the front runners in terms of such kind of academics to take it forward. And I would thank the audience across the country who participated into this session. Thank you very much. I would request to meet for dinner and cocktail. Thank you so much. Thank you, August audience. Thank you very much.
Thank you. Good night.
Please, sir, join for dinner. Thank you for your presence, sir. Please join for dinner.
Hello.